Yes, thank you very much. I appreciate it. So it's an honor to be here and talk about our work. I have no disclosures, and this work began because there is a dogma around the concept that isolated anterior compartment repair will lead to increased posterior prolapse. And the literature on this is sparse, but I think the best paper out there is by Thies and colleagues, where they looked at the 4 defect repair, where they fixed the cystocele, they corrected it, and then they found that 14% of their patients reported posterior prolapse at 40 months of follow-up. And so we started to look at our series on a very similar repair, since they also reported other bothersome prolapse symptoms, and those patients had a reasonable rate of reintervention for prolapse. So the anterior vaginal wall suspension is what we have been doing at Indiana University in the United States for this, where 2 vertical incisions are made beginning at the bladder neck area, and then 4 helical sutures of number 1 or O-proline are placed in the anterior vaginal wall to essentially create a type of a mesh, which is not really a mesh, and then this is suspended using a double prong suture passer such as a Pereira or a Rostami ligature carrier, and this is suspended from the rectus abdominis fascia and muscles. And so in our series we had 84 patients. We removed everybody who underwent a concomitant posterior repair and found that 3 developed this posterior prolapse that the other authors were talking about. So basically 5.4%, and 3 of the patients, in addition to those, started with a posterior prolapse and elected for no repair of that prolapse. And so we also analyzed these patients by doing paired t-tests and found that comparing that way, there was also no significant difference between these patients. So we found our rate of prolapse was relatively low, and then of course, just to show that the procedure worked, we looked at all 84 patients and compared POP-Q points such as BA and found that they were indeed improved at the end of the follow-up period. And the BP points, when you include all the patients that got the posterior repair, also had some improvement, and that validated questionnaires such as UDI-6, IIQ-7 also improved after the repair. And so we did have some complications. We had 1 abscess, 1 suture exposure in the bladder, 1 suture exposure in the anterior vaginal wall, and so from this we concluded that likely this repair doesn't predispose one to have a posterior prolapse. Thank you.
So, any questions, Dr. Powell?
Now, I suppose this was a follow-up study. When did you follow these patients? And then these 3 patients that developed a posterior compartment defect, at what time period was that?
So the one who elected for repair actually had it was about 8 months at her follow-up, and so initially they looked good, but all of them were within the first 12 months.
You said 1 patient at baseline had a posterior compartment defect, but she elected not to have that repaired.
Yes, 3 did, yes. I think that probably is more of a function of my own counseling of the patients. So I counsel the patients that there is a 15% chance of dyspareunia. I use the posterior colporaphy repair with native tissue. And so many patients, when I say that, if they remain sexually active, they choose not to undergo that repair.
Yes.
Hi, Denise Goldman, advocate at Stockholm. I wonder, did you perform pelvic floor ultrasound on these patients to determine the extent of the ballooning?
Yes, that would be an excellent idea. No, we don't, but that would be an excellent adjunct.
Do you? I mean, my thoughts are if you have a posterior compartment defect or maybe a deficient perineum, you're more likely to get a recurrence in the anterior compartment because there's nothing to support it.
That's quite possible. There's a lot of dogma in the area, and I'm not really sure what the answer is, and so that's why I wanted to look at our series where we're doing only isolated anterior compartment repairs and see if our experience matched what was already in the literature. And so I don't know the answer to that, but it's a fascinating question.
This is a surgical technique which is really similar to the four corner colpus suspension by
Yes.
rats. And so I think that the problem it's related to the outcome of this procedure, that we know that it's useful when you have a prolapse not so important.
Mhm.
And if you have a third degree or a stage 2 PAPQ in the time, the majority of this patient has a relapse. And I think so that the problem, and it depends on how much do you elevate the bladder under the fascia. So
Yeah.
I think so that the problem is the outcome in the time, and probably if you follow the patients in the time, it probably is not so important for the posterior compartment but for the anterior one.
Okay, thank you.
Sorry,
Yeah.
it's only a comment.
Just a comment. I
Yes,
read a
yes.
paper only last week. It hasn't been published yet, but it is from the collaboration group in America, the pelvic floor collaboration group,
Mhm.
and they're comprising a lot of different hospitals. And they looked at the results if you do or if you don't do a posterior repair in conjunction with an apical prolapse repair in sacrospinous fixation systems, fixation or sacrouterine fixation. And there was no influence whatsoever whether you did a posterior repair or not. So it didn't help. So it's reasonable to leave it out when there is no symptomatology relevant to the posterior compartment, possibly.
I agree. And to your point, I think when you do support the apex, I think it makes a tremendous difference. I think that helps.
So if there's no further questions, thank you very much.
Thank you very much.